NIMH supports research designed to improve access, continuity, quality, equity, and value of care. And we're particularly interested in supporting new research to dramatically reduce mental health disparities by building an evidence base for effective treatment and care within minoritized and underserved populations from a community-engaged research perspective.
The National Institute of Mental Health, or NIMH, is the leading federal agency for research on mental illnesses and disorders. And that person you just heard is the Institute's director, Dr. Joshua Gordon. That snippet was from Dr. Gordon's speech at the 25th National Conference on Mental Health Services Research in 2022, while he shared some of NIMH's longstanding mission over its 75 years of work. Dr. Gordon has played his own role in guiding the Institute these past 8 years as its director. It's no easy feat. He's overseen NIMH's vast basic, translational, and clinical research portfolio. And he's led NIMH during a time in which public health challenges like suicide and youth depression have been on the rise. But Dr. Gordon and NIMH have still advanced research in suicide prevention, precision medicine in mental health, and more, all with the ultimate goal of helping people like you and me. Earlier this year, NIMH announced that Dr. Gordon will be departing from his role as director and will be returning to Columbia University. His last day at the Institute is coming up on June 14th, 2024. So today, we will reflect on Dr. Gordon's remarkable journey with NIMH. This is Empathy Affect, the Forrest Marsh Media podcast that explores the human side of government. I'm Melissa Harris-Szynski, and today we're fortunate to talk to Dr. Gordon as he wraps up his 8 years at NIMH. We'll examine his role in the arc of progress that NIMH has set in mental health research, how the Institute has tackled the most pressing mental health challenges our society is facing, and his hopes and aspirations for the future of mental health research as he prepares to return to Columbia. Dr. Gordon, thank you so much for joining us on Empathy Affect, especially as you hit this really key and wonderful milestone in your career as you wrap up your time as the director of NIMH.
Thank you for having me here.
Yeah, so, we have so much to talk about today, but I just want to start with some big questions first. So during your time as the director of NIMH, what studies, initiatives, or milestones have you sort of found to be some of the most notable in progressing mental health research?
Well, from that research perspective, I think we've done quite a lot in a number of different areas, but there are some specific programs that I'm particularly proud of. One of them is the focus that we've had on early psychosis and trying to pave a new path forward in terms of developing therapies that are targeted at this early phase of illness, which heretofore has not really been addressable from a therapeutic standpoint. So as many of your listeners know, schizophrenia is a psychotic disorder that strikes in early adulthood. And there is a preceding phase of the illness for many individuals who will go on to develop schizophrenia and other psychotic disorders, which occurs in adolescence and which involves a number of troubling symptoms, including social decline and cognitive decline. And we've been studying that period in illness for a couple of decades now, but we've managed to do two different things from a researcher perspective that are very exciting. First of all, when the first episodes of psychosis hits, NIMH-funded research had shown, actually even before I got here, that a package of care called coordinated specialty care could improve outcomes in these young individuals who are experiencing psychosis for the first time. Applying that package in real-world settings improved their outcomes. What we've now done is in clinics that are delivering this package of care, paid for through a combination of state and federal dollars, we're pairing those clinics with researchers who are engaged in what we're calling a learning healthcare network to improve care in the real time with the outcomes of the data that they're getting from those clinics. The second thing that we've done is set up a public-private partnership to try to do drug discovery that for treatments that will help people in that even before they get psychosis to help prevent them from developing psychosis in the first place. So those two programs, one is called EpiNet, that network of learning healthcare clinics, and the second one is called Accelerating Medicine's Partnership for Schizophrenia. Those two programs are really innovative research programs that we've started in the time that I've been at NIMH.
Dr. Gordon and NIMH have made some important steps in understanding psychosis and schizophrenia. The director said that these conditions, along with youth mental health, are some of the most pressing mental health challenges in America right now. Dr. Gordon, as well as other top public health officials like the Surgeon General, have raised concerns about youth mental health previously. Here was Dr. Gordon on Face the Nation in February 2023.
It is truly a tragedy. It is truly a crisis, and we desperately need to do something about it on a societal level and on community levels. The what is going on question is one that we can't fully answer at this point. A lot of people think, oh, it must be the pandemic and its effects. But if you look at the surveys that the CDC has been conducting for the last decade or more, you can see the slow rise in levels of symptomatology, particularly amongst teenage girls, goes back long before the pandemic started.
Now, at the end of his time as director, Dr. Gordon still stresses that researching and addressing youth mental health is a top issue for the country.
It does represent, I think, the most pressing issue because it's important that we address mental health in youth. Mental illness tends to be chronic illness, and if we don't address it in young people, they may suffer from mental illness or mental health challenges for the rest of their lives. NIMH, from a research standpoint, is addressing it from a number of different approaches. First and foremost, our research over the years has shown you can reduce the burden of mental illness later in life through preventative efforts that can be delivered in schools and in preschools and at home. Preventative efforts early in life, early in childhood. If you teach children how to regulate their emotions, how to negotiate challenges early in life, they will be more resilient later in life. Second, in a sort of secondary prevention, you can show that if you take youth who are experiencing mental health challenges and give them mentoring, strong adult relationships, and access to care, you can prevent those mental health challenges from becoming mental illnesses. And then third, we have a range of different therapies, from psychotherapy to medication to other treatments that can help youth who are experiencing frank symptoms of mental illness. But we need more options, and we need more evidence to understand how to get these preventative efforts and these treatments to the children who need them. And that's especially true in a number of underserved populations throughout the United States, whether we're talking about youth growing up in rural areas or minoritized youth, both in rural and urban settings. It can be challenging for those youth to access care, to access these preventative measures. And so we need to study how best to provide those approaches.
Especially thinking about some of the challenges with helping youth with mental health and, knowing that we know that they need help and you're researching it. So, I was wondering if you could highlight some of the initiatives or programs that NIMH has implemented to help translate evidence-based mental health research into, practical application across different treatment settings.
One of them I mentioned, particularly in psychosis, that RAISE study initially studied this package of care and not just figuring out whether the package of care could work, but how do you train clinics? How do you engage providers? How do you engage people seeking care to make sure that they can get this package of care? That whole genre of research is called implementation science. And we have a range of different implementation science programs that are focused in a broad array of mental health, but especially in youth mental health. One of them is what we're calling alacrity centers. These are centers that bring together psychiatrists, psychotherapists, social workers, and technologists, and engineers, and neuroscientists. And they attempt to work together to figure out how we can use technology, how can we use novel approaches to implement treatments that we know work. Alacrity itself stands for Advanced Laboratories for Accelerating the Reach and Impact of Treatments for Youth and Adults with Mental Illness. We've funded 14 of these centers around the country, and several of them are focused exclusively on youth, including one that's focused on suicide prevention in youth. So these centers, these transdisciplinary research teams, they work with existing clinics that are providing care in communities and try to transform that care using theoretical principles and technological approaches that should enhance care, and we hope will, but even more importantly, should teach us how to transform care in a way that makes it easier to deliver and easier for those who need it to access and to accept.
I love some of the intersectionality you were just talking about there. So just riding that wave, since mental health is also so intersectional across various aspects of society, you were talking about how you could implement it in school with education, maybe employers could adopt different programs. How has NIMH collaborated with other sectors and partners to study and address mental health in a comprehensive way?
NIMH has a number of different collaborations to ensure that our research is addressing the right problems and also is impactful. We collaborate first and foremost with organizations and individuals with lived experience to ensure that our approaches are meeting the needs of those individuals and communities. For example, the Accelerating Medicines Partnership for Schizophrenia program that addresses that early phase of psychosis, that program is done in collaboration with the National Alliance on Mental Illness and a number of other public and private groups, including groups that are led, like NAMI is, by individuals with lived experience. Another sector that we collaborate with are providers of care. And in particular there, we work with a federal agency, the Substance Abuse and Mental Health Services Administration, which gives grants to the states. And through those grants, funds the psychosis centers that I mentioned before, but also certified community behavioral health centers and other mental health treatment efforts. And we work with them first and foremost so that they're aware of the evidence-based practices that come out of NIMH research, and they can encourage the use of those practices in their funded clinics, but also to help us figure out how we can study mental health treatments and approaches in these community-based clinics, like I was mentioning before. Then we also engage in a number of what we call multi-sectoral partnerships, where we work with members of industry, members of advocacy groups, and other federal agencies to try to ensure that we're all working together towards a common goal. One of the most satisfying partnerships that we participated in, for me personally, is the National Action Alliance for Suicide Prevention. NAASP, as its initials are known, brings together members of these different parts of the healthcare ecosystem, including healthcare providers, insurance companies, for-profit companies that buy those insurances, nonprofits that are advocacy, and federal agencies, to come up with approaches towards preventing suicide and promulgate them throughout our networks. So we've, for example, been advancing an approach for healthcare systems called zero suicide, which our researchers are studying even as they're being implemented by the healthcare providers who participate in NAASP and with the help of the companies that are paying those providers to give care to their employees. So, and our research is beginning to show that zero suicide approaches can reduce suicide attempts and suicide deaths in the context of a healthcare system that's trying to reduce suicide deaths through a range of different approaches. So these partnerships can be really important to help bring our research into practice.
Absolutely. I really love to hear about those collaborations. I think it's hard to feel like you can move the needle forward when you're only in one part of a very complex public health situation. So thank you for sharing some of those. I think I want to spend some of the interview now getting into some of your accomplishments, just reflecting on your career. Just off the bat there, what are you most proud of during your time as the director?
It's hard to pick one thing. I guess what I'm most proud of is providing opportunities for the wonderful scientists and other employees of NIMH to do their outstanding work in a collaborative and cooperative environment where innovation can really occur. We've spent a lot of effort within the organization ensuring that we participate in dialogue about our science, both within and outside the organization, that we listen to everything that all of our employees bring to the equation. And through that, we've generated some really innovative ideas. One of them I mentioned already is the Alacrity program, these centers for implementation science that combine technological and mental health approaches to try to improve care delivery. Another one that I'm really super proud of, not just because it came from this environment where people can think creatively and work collaboratively, but also because it's been a priority of mine for some time, is in the area of precision psychiatry. We've recognized over the last dozen years or so that there are a number of different approaches that we can use to study our patients that have the potential to give us better predictive power, particularly, for example, in depression. As you know, we have lots of treatments for depression that work in different ways. We have medications and different kinds of medications. We have psychotherapy. We have 3 or 4 different approaches to stimulating the brain. So we have all these different treatments, but we can't tell which patient is going to respond best to which treatment. And so treatment selection in psychiatry for depression is mostly a guessing game. But there are all these hints from a number of different academic studies that if we image the brain, or if we do an electroencephalogram, measure brain waves, or if we do some behavioral tests and measure things like motivation or enjoyment or cognition, that we can dissect the heterogeneity of depression and learn something about our patients, and maybe even tell which patients are going to respond to which kind of treatment. But these are all small academic studies. And they're not done in a way that enables a doctor to say, oh, if my patient has depression, I'll do this test and that test and the other test, and I'll figure out which treatment might work best for them. So we created what we're calling an innovation funnel for biomarker advancement in depression. This program, which was just being launched now, we're just about to award the first few grants, will fund a lot of investigators to bring their best ideas forward and in a pilot phase, demonstrate the potential of each of these ideas to predict for a given patient which treatment might work better for them. After this initial pilot phase, we'll fund those same investigators, a subset of them that have proven best that their treatments work. We'll fund a subset of them to do a prospective small-scale clinical trial to demonstrate that their biomarker will improve care. And then again, we'll select the best of those and do a large-scale phase 3 clinical trial that can qualify that biomarker for FDA approval. So this process will take a while because we have these 3 different phases. By the end of the process, we should have the first test that we can use in psychiatry to treat depression. So these precision approaches have been talked about for a long time, but because there hasn't been this concerted push, we haven't advanced any of these approaches to real-world clinical situations with strong confidence. So we're very excited about this innovation funnel approach. And I'm really proud because it's a creative idea that came from the staff through collaboration and that we're really moving forward in an exciting way.
Yeah, I know that precision medicine has generally been a really big area of interest for NIH. I've seen it at NCI. So it's really awesome seeing how it's working here in the mental health realm. I myself have been on the journey of trying to figure out the medication that works best. And so if that could be applied to the real world one day, that would be really amazing. You were mentioning how that program was just starting. So I'm wondering now, as you're, about to leave in a few weeks, in your final stretch now, what legacy do you hope to leave with the Institute?
Well, I hope this legacy of creative collaboration and openness to ideas throughout the organization will continue long after I'm gone. I think we've really worked hard on making a culture change at NIMH to accommodate these ideas, and I hope that will live on. From a scientific perspective, the precision psychiatry approach is one part of really computational psychiatry, which we've been emphasizing for the entirety of my time here at NIMH, that infuses many other parts of the portfolio. And I think that is a legacy that will absolutely live on. You see these mathematical and theoretical approaches being brought to bear, not only data science and big data, but that is a piece of it, but also trying to get down to mathematical descriptions of behavior and use those descriptions of behavior to better attack the neurobiology underlying it with, again, the aim of applying that neurobiological understanding to mental health. So the computational psychiatry is broader than just the precision approaches that I mentioned, but I think that's another legacy that will absolutely live on.
These are certainly wonderful legacies that NIMH has taken to heart and I'm sure will last going into the future. So as you reflect on your tenure at the Institute too, I'm wondering what has surprised you most during your 8 years at NIMH between when you first entered and where you are now?
I don't know if I would use the word surprised, but I would say I've been really amazed at how everyone at NIMH, from the intramural scientists doing research, extramural scientists working on grants and policies, to the administrators and to the people who take care of the office, they are all committed to the NIMH mission. They're deeply committed to improving mental health for people. And that spirit, that commitment to mission is astounding. It's beautiful. And I didn't anticipate it. I'll put it that way. And it was wonderful to be a part of this committed group of people for 8 years.
Yeah, I feel like with many of the guests across our show, they always praise the people working to make each of their agencies' mission work. It's always their North Star or a driving part of what keeps them motivated. So it's been great to hear about the arc of how NIMH has changed while you've been the director, but just based on how you see the Institute now, where do you see the priorities and goals advancing beyond your time there?
Well, actually, this is, for me, the really exciting part. I don't know. Part of the reason for me to leave is I feel like I've done what I set out to do almost 8 years ago when I took over NIMH. And I'm excited to see what the next person brings. NIH has a wonderful tradition of directors coming and directors going. And when the new director comes in, the new director will bring, I hope, exciting scientific priorities to NIMH to add to what we're doing now. And so I don't know. And I don't want to predict because I want to see what the next person will bring.
That's a completely fair answer. Now, as you leave, you're going to be returning back to academia at Columbia University. Congratulations.
Thank you.
So, in this next step, what are you most excited about as you take this next step in your career?
I'm excited about several things. I'm excited first and foremost about going home. I've been living a split life for 8 years, except during the pandemic. I live in New York, commute down to DC. It'll be nice to be in one place and have my life in one place. I'm excited about the opportunity to lead in a different way. Leading a large and successful department of psychiatry is a different challenge than leading an organization that funds mental health research. And I'm excited to be back amongst friends. Many of the people that were at Columbia 8 years ago when I left are still there. They're good friends, and it'll be good to be back working with them again.
It's always good to go home. I myself am from New Jersey, so welcome back. So what have you learned from your time at NIMH that will inform your new position as you return to this more clinical academic setting?
I think two things. I've really learned how to lead. I left Columbia having a small lab and minor administrative responsibilities, and I've learned on the job here at NIMH how to lead a large and complex organization, and I hope to bring some of those leadership ideas back to Columbia and enriching the group there that's already doing so well. The second thing is this breadth of research. I definitely did not appreciate the breadth of mental health research back when I was running my own lab and focused on my own area of interest. And it's been wonderful to learn about things like implementation science that I knew nothing about before I came to NIMH. And I hope to be able to bring that understanding, that broader understanding of research back to the department, and therefore be supportive of the full breadth of what the faculty are doing there.
I'm sure that going from the director of NIMH back to, this new position will really help you thrive. I mean, just the number of stories you've told today have been amazing to see. So as we wrap up here, what message would you like to share with the broader community about the importance of mental health advocacy, research, and collaboration in moving the needle forward, improving outcomes for individuals affected by mental illnesses?
I would like to say mental health research works. I didn't mention it before, but during my tenure at NIMH, we had 3 novel drugs approved for mental illnesses based off of NIMH-funded research that I didn't do. It was research that happened in the past. It takes a while, but those research investments resulted in the improvement of a new drug for treatment-resistant depression and 2 different drugs for treatment for postpartum depression, the first ever treatments that are specifically targeted at postpartum depression. These are just a few of the public health advances that came out in the last 7 or 8 years as a result of past NIMH research, and the research investments that we're making now will make dramatic improvements in mental health in the future. So research works. That's the message I'd like to give out.
One more final question. Is there anything that we didn't get to today that you want to share with our listeners?
I would just say thank you to your listeners, because it's your tax dollars that support this amazing organization that I work for, and it's their commitment to mental health matters that fuel the interest in mental health research and the ability to make progress. So thank you.
Thank you so much, Dr. Gordon. I wish you all the best in the next step in your journey. We're so honored to have had you as the director of such a wonderful institute the past 8 years.
Thanks, Melissa. Thanks for having me.
Cheers again to Dr. Gordon as he wraps up his upcoming final week with NIMH. If you want to learn about Dr. Gordon's accomplishments or NIMH's research, we'll link to them in the show notes. Also, if you or a loved one are in crisis, make sure to call or text the Suicide and Crisis Lifeline at 988. Thank you, as always, for joining me on Empathy Affect. If you've enjoyed today's conversation, make sure to follow, subscribe, and share the show with a friend. And don't forget to rate us on the podcast platform of your choice. Thanks, y'all.
Empathy Effect is a product of Forrest Marsh. You can reach us at forrestmarshmedia@forrestmarsh.com with any feedback, questions, or inquiries. If you want to know more about today's guest, are interested in participating with Forrest Marsh, or becoming part of our community, check out our show notes for more information.